Thank you very much, Mr. Chairman and panelists, and thank you for everybody for being here at the third National Heart Forum, and looking forward to really an exciting program. So my first talk today, or the first talk of this forum, and this first talk of this session is going to be a very brief and concise talk. What is the role of Saha Virtual Hospital in really putting together teams and having MDT programs? And we had a great example of cases going for TAVI. Okay. How does this move? It's not moving. مش بتتحرك. طب ولا من الكمبيوتر ما بتتحرك؟ Okay. So just لا هي هناك حطوا this take it off. حطي هنا. Okay, that's the one. That's the presentation, yes. Okay. Okay. We need audio-visual support. Okay, now it's working. So aortic stenosis is a problem. Around 41 million people have valvular heart disease in the world. About 9.4 million of them have calcific aortic stenosis, which is the most prevalent valvular heart disease in the world. It's slowly progressing due to the aging populations in the world. And if you can see in the graph here that 0.3% of the population that are the age of 50 to 59 have severe calcific aortic stenosis, and around 10% from the population of 80 to 89 have severe calcific aortic stenosis. Aortic stenosis has many health-related complications, bleeding tendencies, heart failure, sudden cardiac death, infections of the heart, and an irregular heartbeat. In Saudi Arabia, we project that the prevalence of aortic stenosis is expected to increase as life expectancy is increasing. As we know that in 2016, the average life expectancy was around 74 years of age. And now, as we speak, it's around 77.8, and it's part of the Vision 2030 that we want a life expectancy of 80 years. An average life expectancy. Now, with having said that, we will have more and more cases of severe aortic stenosis, because an estimated 2 to 7% of the population of Saudi Arabia will have, or the population above 60 will have aortic stenosis, which is also comparable to high-income countries. So by 2050, there will be a five-fold increase in the population that are over 60 years of age, from 2 million now to around 10.5 million by 2050. At Saha Virtual Hospital, we assembled an MDT, a multidisciplinary team, cardiologists, cardiac surgeons, interventional cardiologists, imaging cardiologists, and cardiac surgeons, to really discuss these cases, very complex cases. We discuss cases from all over the country, from Jizan, from Najran, from Tabuk, from Al-Ghurayat, from Arar, from the far south, far north, far east, far west, and also in the central region. Why do we need to discuss these cases? Because these are a really complex patient population. So TAVI patients often present with multiple comorbidities, complex anatomy, and higher surgical risk, necessitating diverse expertise. Also, there is comprehensive assessment. They need comprehensive assessment So an MDT allows for holistic evaluation and risk assessment. Also, these MDT meetings really enhance patients' outcomes. And I still remember a few cases that before we started this project, where I hear disasters happening here and there because of poor planning or poor execution or poor follow-up. These MDTs are there to support and help and also to educate. So sometimes we have these sessions, and during these sessions we educate the centers that are starting these the TAVI services, and sometimes we use it as a tele-proctoring or tele consultations for those centers. Key members of the TAVI multidisciplinary team, some of them we have them in our MDT at Sahha Virtual Hospital, and some we don't. So interventional cardiologist, we have interventional cardiologist considered the best in the country, and they come and go, and we have people that are attending some meetings and missing some because of their busy schedules. But we have always experienced interventional cardiologists, experienced cardiac surgeons, experienced imaging cardiologists. We have an anesthesiologist and an intensivist and heart failure specialists. These are some of the questions which I want to illustrate the complexity of aortic stenosis or severe calcific aortic stenosis when we wrote one of the really best guidelines in the world, which is the TAVI, the NHC, SHA, SASIS, surgical SSCS, and surgical and cardiac imaging working groups. We wrote one of the beautiful, really, guidelines in the world, which is the Saudi TAVI guidelines. These are just some of the questions that are there. So there are very straightforward cases, which is severe symptomatic aortic stenosis with prohibitive risk of surgery. That is a no-brainer. They go for TAVI. But there are others that really have the needs that heart team meeting and need that joint opinion and need the discussions of the experts to reach the best solution or the best decision and the best outcome. Like, for example, severe TAVI with severe symptomatic AS with concomitant coronary artery disease. Not every case is as the other, and we really need to discuss I lost a few minutes, so give me just a couple of minutes, I'll finish. So these cases, we really need to discuss the coronary anatomy. We really need to discuss the best option for these patients. Patients with severe symptomatic aortic stenosis and a bicuspid aortic valve. Patients with symptomatic aortic stenosis with concomitant significant mitral valve disease. And imaging, do we need to do a coronary angiogram or a CTA for coronary assessment is enough for TAVI patients? For pacemaker insertions, how long do we wait until a pacemaker a permanent pacemaker needs to be inserted? All these questions and many, many more are really very important to address to a wider group of experts. And sometimes a lot of the periphery, especially the periphery hospitals, that want to start a TAVI program. And we don't really mind them starting a TAVI program, as a lot of these centers, they have interventional cardiologists trained to do TAVI. But probably they don't have a very experienced imager or a very experienced electrophysiologist that really could look at ECGs and tell him that, no, this patient will recover and this patient will not recover, and how long do we need to wait? So this is just an example of a recommendation that is really straightforward. TAVI for severe symptomatic aortic stenosis in patients or not, younger than 75 years of age. Then this is in our recommendation. TAVR is a class 1 recommendation, level of evidence BA. TAVR is also recommended for severe for less younger than 65. TAVR is a class 1 recommendation, level of evidence A, and for 65 to 75, TAVR is a class 1 recommendation, level of evidence B, and from 65 to 75, we here clearly stated that TAVR is a class 2A with a level of evidence C. So it's more of a straightforward, but it's always, there is always the issue of, or the pointing out that a heart team discussion is always part of all the guidelines, of all the recommendations in this guideline. It's TAVI with severe symptomatic aortic stenosis with bicuspid valve. So TAVI is a class 2A recommendation, level of evidence B, and there is always the word after heart team discussion, after heart team discussion. And this is also just another example, early replacement or versus watchful waiting for severe aortic stenosis in asymptomatic patients. So there is no evidence to support TAVI for severe aortic stenosis patients who are asymptomatic. TAVI may be an alternative to TAVR in specific patients after heart team discussion. So the availability of heart team is front and central. And in Sahha Virtual Hospital, we provide the service for any center that wants to have that on their record, that they discuss this patient in a heart team meeting. We are ready to discuss your patient. We are ready to go through all the data with you. If you don't have an electrophysiologist, you don't have an expert imager, you don't have an expert cardiac surgeon, or you want to start the service and you want also tele-mentoring and tele-proctorship and also physical proctorship, we are willing at Sahha Virtual Hospital to do this. In Sahha Virtual Hospital, since the beginning of this year, or the beginning of last year when we started this service, we discussed a total of 693 patients in our National Heart Team committees. We saw around 902 patients in our virtual clinics. We monitored 243 severe heart failure patients and post-PCI, post-CABG patients with remote patient monitoring. We had 19 live cardiac intervention streaming and tele-mentoring and tele-proctoring. The total beneficiaries, emergency consultations of 97, and total beneficiaries of 3,375 patients. These are the centers that we are connected to. We are connected to more than 61 hospitals. We have a total of 34 consultants working with us in Sahha Virtual Hospital. And we also discussed and did teleconsultations for 75 international cases from different areas in the world. These are the TAVI cases that we discussed. Some of them, as I said, like in the Riyadh cases, they were more teaching to other centers on how to evaluate cases and how to go forward, and we gave them follow-up on those cases. But we had around 6 cases of TAVI that we helped Taif in dissecting, analyzing, and going with, or we gave them the best treatment options. Jizan and Tabuk were the most active. 10 cases in Jizan, 16 cases in Tabuk, and 5 cases in Najran. This is the impact of the National Virtual Heart Team or Heart Committee in the outcome. So a visiting consultant went there to assist with the surgery, with the intervention in 29% of cases. The local team, after just supporting them with a decision support, they performed that procedure successfully in most of the cases. And I don't recall really that we discussed the case and a case went bad. 41% the local team did the complete job, and 30% it was a combination between either we virtually supported them or we transferred the patient to a higher center. This is just an example of a patient that we discussed, a 79-year-old patient presented to the Tabuk team, very high-risk patient, ejection fraction 25%, coronary artery disease including RCA and LCX, and severe aortic stenosis, low flow, low gradient, PCI with Impella, and TAVI was done so these are his coronaries. You can see the coronaries were quite bad, and TAVI was done successfully for this patient. There is another case, an 80-year-old patient presented to Jizan team, very high-risk patient, ejection fraction of 20%, multivessel coronary artery disease, including left main and LAD, and severe aortic stenosis, low flow, low gradient, PCI with Impella and TAVI was done successfully, and this is just this was done with a balloon expandable. This is with a self-expandable, so at the end, my take-home messages is Sahab Virtual Hospital is here to support all the centers. We could really provide high-value care to your patients by having the patients stay at the comfort of their city, at the comfort of near their home, near their loved ones and families, and we will come to serve you where you are. We will come to serve your patients where you are. We have a great team, more than 34 consultants working with us in Sahab Virtual Hospital, and really looking forward to participation, more and more participation of all the centers, and thank you very much.